key message is that we have placed Irish general practice in an international setting. There are extremely good things about general practice in Ireland. Over 90% of patients are satisfied with their GP. In any industry, that's a very significant finding. Now, they do want the GP to do more, particularly in the area of mental health. They want the GPs to have better access to diagnostics, and so do the GPs. That's exactly what the GPs want as well. The young GPs are not keen to join the GMS system as it is at the moment, but they're very motivated by thinking that there will be a new contract available that will permit them to work in teams. The GPs coming out have told us in this research that they are quite interested in being salaried for a number of years. They then are ready to take on a GMS contract, and they then want to become or will be interested in becoming managing partners. Now, that's quite an important change in the way things go on. The other thing that came across is they're not that interested in single-handed practice, and that has, of course, significant implications for parts of the country. The area of continuity of care is extremely important. The research shows that where a patient sees the same GP on most of the time, admission rates to hospital are significantly lower by about 12.5%. Now, the good thing is in Irish general practice, there is a long tradition of continuity of care, sometimes within the same GP's family, looking after patients for maybe 3 generations. So there is great continuity of care. But it's very important that continuity of care, seeing the same GP as often as possible, is extended to the area of long-term illness. Long-term illness, you can call it chronic diseases if you want, but chronic diseases are much more it's a medically defined term. GPs see patients with long-term illness, which include chronic diseases, and that is valued enormously by patients. It improves their compliance with their medications. It gives them a much more optimistic outlook on their illness, and leading to significantly fewer hospital admissions, attaches a monetary value to continuity of care. Practices, of course, have to gear up to provide continuity of care. It means fewer locums, short-term locums, for example. It means a commitment, a longer-term commitment by the GP to the practice. It means being on the lookout for patients. It means fitting them in at certain times. And it does mean taking risk. But the evidence is that this pays off for the patient and for the unnecessary hospital admissions. The quick wins, I think, for the system, and certainly if we look at the North American experience, the quick wins have been the appointment of additional staff to the practices to allow GPs to function at what the Americans call the top of their license, to do the things we're trained to do. In a morning surgery or an afternoon surgery, we do a lot of things that could be done by other people, that could be done better by other people. And it doesn't mean the work's going to run out. I think the international experience is to move more and more work into general practice, but that has to be resourced. The resources in our system are not great. About 4.5% of the health budget goes to general practice. Now that has to increase. GPs have been very entrepreneurial in the way they have managed that budget. It does mean, for example, that 60% of our patients who are not covered by the GMS, we have to put a better system in place for them so that we have continuity of care. And this means that our private health insurance industry has to play a part in this area. And that requires pressure on them to do it. It requires political pressure, particularly because and I do think that our private practice income is low and our private practice care of patients is not as extensive as it should be because it has been hived off into other secondary care systems, which is a very expensive way of looking after people. The other area that came across in compiling this report is the data, and this is international data. International data has not been, has to come with health warnings. The international data is evolving. Some of our international primary care systems have good data. We don't. The data always has to come with health warnings. We've had to look in all kinds of places to find data. And that does mean that when we as GPs or the HSE throw figures about, there is always a suspicion that it's trying to be, I suppose, increased or pumped up, which doesn't give any great confidence to our politicians. So one of the things that I would very much like to see arising from this is that a number of practices are resourced to collect data and that data is handled independently by an independent body, which includes the GPs and people who are involved in primary care, to help us plan for the future. Because if we have better data, we can plan in a much more responsive way for patient care. The other area which has to change is our access to diagnostics. If anything, our access to radiology has got worse over the last few years. And that has to change because the young GPs, the GPs in training, told me that they find it disrespectful to their clinical skills, that as a junior hospital doctor they can order complex radiology. And when they come out to general practice, they have to beg or use their networks to get radiology. And if we don't have access to that kind of diagnostic service, it means the patients end up unnecessarily in hospital. Now, that is an area that, for example, a transitional fund can help to resource primary care, to resource clinical practice. The other area is the IT, which needs to talk to each other. Practice systems don't talk to each other. Our primary secondary care systems don't talk to each other. And this concept of interoperability is very important. And I think it is, again, once it's resourced and developed, it will run on itself. Otherwise, we're missing out on opportunities to have data for planning for the future.
Excellent.
Load of stuff on that.
Yeah, plenty there anyway.